afternoon and warm greetings to everyone joining from across the African region. My name is Tendai Makamure, and I'm an infection and prevention and control specialist with the World Health Organization, and I'm based in the Nairobi Emergency Preparedness Hub. I want to start by thanking you all for joining this important session where we are going to share the important guidance, the updated recommendations on infection prevention and control for home-based care for healthcare facilities, specifically for Mpox. And with that in mind, we'll start with the housekeeping slides, which will be presented by Amarachi. Amarachi, over to you.
Good afternoon, good morning, good evening, colleagues, wherever you're joining us from. Thank you again for joining us. As Tenda had already said, I'm going to quickly run us through a few housekeeping. As you know, WHO events are guided by the highest ethical and professional standards, and all of us are expected to behave with integrity and respect towards each other, participants or panelists attending. Next slide. We have interpretation available in French and English. You just look at the bottom of your screen, you will see a globe icon that has under it interpretation. You click on that and it will enable you to listen in the language that you are most comfortable with. If you do not want to hear any interferences, please mute original audio so that you can only listen in that language that you're comfortable with. Colleagues, please use the Q&A for questions regarding the topic and presentations or the technical area we're discussing today. Only that. Please do not introduce yourself in the Q&A. Do not talk about IT issues in the Q&A. However, for the chat, please use the chat to introduce yourself. As we've already seen some of our colleagues begin to do, please tell us your name, your institution or organization, and also the country where you're joining us from. We are very happy to have you here today. When it is time for the live Q&A, our moderator Tendai is going to ask you to raise your hand so that she can give you access to ask your question live. Now, for some of your screens, the raise hand is just there. You can see it. It's a hand that goes this way. But for some of your other Zoom platform, depending on the laptop or the Zoom version that you're using, you have to go to the React button. So you click on the React button and then you're going to have raise hand and you can raise your hand from there. We encourage you to please ask your question live and interact with the panelists that we have on the call today. Next slide. Great. By participating in this meeting, whether as participant or panelist, we take your attendance as permission to record your contribution. So it could be your question, either live or the one that you put in the Q&A. And we are going to be sharing this via our various learning channels for continuous learning purposes. Now, in the coming days, I am going to be sending you the session materials and the session recording. And so you can also expect that. Next slide. So all of the data that we've collected from you during registration, if you remember your name, your country, all of that, we have them and WHO keeps them confidential. We may be using some of that data for report, for maps, for communications or survey, but all of those will be de-identified before use. Next slide. So today we have mainly 3 objectives, and one of them is to highlight the IPC new recommendations and guidelines for Mpox. Today we're also going to be discussing practical approaches for safe home-based care, the caregiver protection, waste and environmental cleaning and disinfection. And lastly, we'll be getting some experience from some of our countries and lessons learned about implementing home-based care during Mpox outbreaks. Next slide. I'm going to quickly run you through the agenda before I hand over to our moderator. Our opening remark is by Dr. Diano Balde, who is the WHO Incident Manager for Mpox. Unfortunately, he will be represented by Dr. Solomon, who is our emergency response team lead at the Nairobi hub. We're going to have a presentation on introductions and the overview of IPC guidelines, guideline process and publication updates by Noshin Usman, who is the technical officer and part of the IPC and WASH team at the WHO headquarters. We'll also get a technical session that covers key IPC measures for safe home-based care, and that'll be done by Dr. April, who's the team lead IPC and WASH, Safe and Scalable Care, also WHO headquarters. Our country experience would be from Zambia, and here we have the Chief Environmental Health Officer, who is Mr. Innocent Amuganyo, and he will be talking about current IPC practices and challenges for implementing home-based care. We'll then take on 20 minutes of Q&A, where again, I encourage you to please raise your hand and ask your questions live. While the session is going on, please put your questions in the Q&A. And during this Q&A session, please raise your hand and ask your questions live. And then shortly after that, we'll have next steps and closing also by Dr. Solomon, who is our emergency response team lead at the Nairobi hub. That'll be all from me. Welcome, everybody. Over to you, Tendai.
Thank you very much, Amarachi, for taking us through the housekeeping. And colleagues, before we begin, I want to start by acknowledging our technical experts from the HQ, WHQ, or HQ, and from the regional office, and also the country office for Zambia and the Ministry of Health Zambia for all the great work that they have put in making this webinar a success, and also particular appreciation to the ECHO team. So without further ado, I would like to introduce our Dr. Solomon, who's going to do the welcome remarks. He's the Senior Emergency Officer in the Nairobi Hub. Over to you, Dr. Solomon.
Thank you very much, Tendai. Thank you, Madachi. Thank you, colleagues, and welcome to this webinar. I hope you can hear me loud and clear.
Yes, we can hear you.
Okay.
Yes,
Okay,
you are
thank
very
you.
loud and clear, Dr. Solomon.
So, good morning, good afternoon, and warm greetings to all member states, partners, and colleagues joining today's important session. Apologies from Dr. Tierno. Unfortunately, he was not able to join us in this meeting, but I'm sure you might have interacted with him in one way or the other. He might join us in future trainings or meetings as well. So allow me to just deliver a few remarks. As you know, WHO has declared the end of the global Mpox public health emergency of international concern on the 4th of September this year. However, the virus remains a serious threat, particularly here in our region in Africa, where more than 600 new cases are still being reported every week across 22 countries. The number of countries can vary from time to time, but more than 20 countries are reporting. WHO continues to classify Mpox as a grade 3 emergency. This is the highest level of emergency for WHO, and we assume this internally, allowing us to mobilize maximum technical and operational support to member states. Progress has been made in the past years. As you know, we have achieved better capacity, especially on testing. We have expanded vaccination, even though the availability of the vaccine is still a challenge. And we relatively have safer clinical care, but still we have several challenges. We have limited funding, especially with the current humanitarian context, as you all know. We have staff shortages at all levels. And we have health workers fatigue with several emergencies going concurrently. The issue of stigma is another critical problem that we are facing on the ground. Misinformation is also going on in spite of the efforts that we have made over the years. And there is persistent gap in IPC implementation. That's why we have this webinar. Let me say a few words on the transition phase. As you know, as we have declared, as WHO has declared the end of the public health emergency of international concern for monkeypox, but it has been emphasized that we have to shift from emergency response to sustained routine health system action. Monkeypox is likely to remain with us, to stay with us, and we have also to adjust our service and our response. The Continental Mpox Transition Roadmap and the WHO Strategic Framework for Mpox 2024-2027 is guiding this shift, or is aiming actually in guiding this shift, aiming for Mpox control and eventual elimination, possibly by 2027. Our collective task is to ensure that IPC, one of the most effective and cost-efficient intervention, moves seamlessly from emergency response into everyday national health programs. And during this training, this webinar, that is what we are going to focus on. Allow me to say a few words on the key IPC issues that we must address during this phase. Home-based care. In many African countries, and in the context that we live in, home isolation and care are unavoidable due to the limited facility capacity and the socioeconomic realities. Implementing IPC in such settings is not an easy task. In some places with crowded households, lack of running water, the cultural practices, and stigma all create barriers. The new WHO guideline provide practical recommendations for infection control in home-based care, but member states will need to be innovative and context-specific to make them work, adapting messages, providing IPC kits, and leveraging community health workers. In addition, we have to consider the issue of health system integration. As dedicated Mpox response teams wind down because of the emergency phase is phasing out, IPC activities must be embedded in routine service delivery, from primary care clinics to district hospitals, and of course, at community level as well. This requires revising facility SOPs, budgeting for IPC commodities within national health plans, and maintaining trained IPC focal persons, even outside outbreaks. Therefore, I would like to have the following critical call for action. Transition doesn't mean complacency, but instead it demands that we protect and build on the capacities gained during the emergency. Early warning systems, rapid detection, and strong community engagement are strengthened. I would like to urge all member states to adopt and adapt the new IPC Mpox guidelines to national context with a special focus on home-based care feasibility. Integrate Mpox IPC measures into broader infection control programs, linking with routine surveillance, immunization, primary health care, and the other programs as well. Innovate and share solutions from low-cost hand hygiene stations to culturally sensitive risk communication to overcome the practical barriers we know exist. So WHO and partners remain committed to supporting you in this transition. Technical experts, on today's panel will walk through the new guidance and share country examples. Together, let's ensure that the progress made in Mpox response translates into stronger, more resilient IPC systems, protecting our communities today and preparing for tomorrow's outbreaks. Thank you for your dedication and for joining us on this critical journey. This is a moment to innovate, integrate, and institutionalize IPC so that Mpox control becomes a permanent strength for our health systems. Remember, if we use opportunities, disaster can be considered as an opportunity. Let's take this as an opportunity and see how we can move from where we are now to a better position where our communities can be in a better capacity, in a better position when in the future and when other emergencies appear as well. Thank you very much, and I wish you all the best during your deliberations. Thank you.
Thank you very much, Dr. Solomon. Indeed, institutionalizing infection prevention and control in our healthcare systems is the key message here, so that all the opportunities we have had, we now build resilient systems, we build on them, and we have a more resilient health system. So I think as our webinar starts now, colleagues, to those who are just joining, I want to welcome you. As we are now going into the presentations, I want to encourage us to really listen through so that we understand all the critical guidance and the updated documents that will be shared by our presenters, and also to inform you that at the end of each presentation, we'll be having poll questions, which will need you to respond to make the session more interactive. And also just to reiterate that for if you have questions as the presentations are ongoing, you can put them in the Q&A for the questions. So with that, I would like to invite our first speaker, Noshin Osman, who will provide the overview of the IPC guideline development process and also the rationale behind this new IPC recommendation. Over to you, Noshin.
Thanks, Tendai. As Dr. Solomon has set up the scene very nicely, I'm here to present the overview of the IPC guidelines, development process, and the publication updates of all the Mpox package that was developed over the past few years or over the last year. Next slide, please. So just to give you a little bit of background, that what triggered the development of the case management and IPC Mpox guidelines in 2025. As you know that the global outbreak was first announced in 2022, where WHO produced interim guidance in 2022. Since then, we have seen increased availability of clinical and epi data, as well as including transmission-related information, evidence, and more case management experience have been documented. And since August 2024, we have the emergence of a new clade 1B, which leads to the declaration of fake in August 2024, and we have seen the changing transmission patterns. In order to improve quality of care as it can reduce mortality and morbidity, also we address that ensuring the protection of healthcare workers as well as patients who seek care are safe. Next slide, please. So the process of developing the first evidence-based living guidelines on Mpox and IPC, which was published in May 2025, in order to come up with the new recommendation, WHO commissioned an updated systematic review on IPC measures to reduce Mpox transmission, which is based on expanding the publication and study which was conducted in 2023 and published in 2024. But the recent systematic review, which was conducted by WHO, is not yet published, though the findings are incorporated here. So the key findings of the updated review is that more than 95% of transmission occurred through direct physical contact, both sexual and non-sexual, with skin lesions or lesion exudate. No confirmed cases have been reported on inhalation-based transmission. Only one case of self-reported droplet exposure was identified. Health and care workers' infections were rare and primarily due to needle stick injuries during specimen collection or clinical procedures. So these findings informed the updated IPC recommendations. WHO convened a multidisciplinary Mpox GDG, which are composed of experts on infectious diseases, IPC, clinical care, public health, HIV, pediatrics, and maternal health. So in all these meetings, the GDG adopted evidence to decision framework approach, which leads to the evidence, which obtained evidence from the systematic review and used, and this evidence has been used to formulate statements, which are updated, and also recommendations and good practice statements. Next slide, please. So what's new in the new guidelines which are published in 2025? So based on the previous WHO interim guidance in 2022, this is integrated IPC and clinical management guideline. We have in total 7 new recommendations, where 2 are IPC recommendations and 2 good practice statements overall and 1 good practice statement for IPC. So for IPC measures, there is 1 updated recommendation for healthcare facility setting, and the other one is on home-based care. And also, these guidelines can be adopted as a standalone document, also adopted according into the national guidelines. These are living guidelines, and it will be updated based on the as the evidence become available or new recommendations will be added. Next slide, please. So these are all the derivative tools and IPC guidance documents that were developed over the past year to help implement the IPC and WASH measures both in communities, in healthcare facility, and also to support the coordination. So you can see that it's a very integrated approach, and we have tried to address all the IPC measures that are required both at the community level and in healthcare facilities, and also how to implement it through the coordinated structure. So you can access all these guidelines on WHO page as well as on here from the slide. Back to you, Tendai.
Thank you very much, Aditi, for the great presentation and for giving us a clear overview of the guideline development process. I think you have set a pace and made us understand why these new updates were needed. And I think we can now proceed to the poll. Dear colleagues, we are now going into the poll questions. They will appear on your screen and you can select the correct response. And for the third question, for you to see more responses, you need to scroll down. So the first question is, were you familiar with the updated WHO case management and IPC guidelines that were published in 2025? You can select the response. You have 3 minutes, then you can progress to the second question. And for the second question, to see all the responses, you need to scroll down. The second question, from the systematic review, 95% of Mpox transmission was true. You need to select the response based on what was presented by Noshin. And then on the third question, there are also responses there. Which tools were most helpful in your current roles, in your settings where you are working? And there are responses there from which you can select. I'll give you 1 minute to go through that, then we see the responses. A few more seconds to go, colleagues. I think we are counting down from 30 now. Thank you so much. I don't know how many responses have we had, or do we need more time? What's the percentage of on the response rate? So from the poll question, from the first question, we can see that 75% of the people indicated that they were not familiar with the updated guidance on Mpox, which were published in 2025. So I think this webinar is timely because we are the right target market, and you will now all be familiar with the updated guidance and the recommendations. On the second questions from the systematic review, 95% of Mpox transmission was through, 73% was direct contact, 1% responded inhalation, droplet exposure, 8%, and 18% said all of the above. I think from the presentation that Noshin has made, I think she will show us again just now that it was direct contact. And I think it is really important for us to understand the mode of transmission, for this is the basis of all the guidance and the recommendations that are going to be shared. It guides all the IPC interventions. Then thirdly, which tools were most helpful in your role? I think most people have said the IPC and WASH strategy followed the PPE posters. Thank you so much for this feedback. And I think we'll just clarify on the first one on the mode of transmission. Noshin, if you can just comment on that before we progress to the next presentation.
Thanks so much, Tindai. As I've reported that the study, the systematic review reported that more than 95% of the transmission occurred through close direct contact. So there is only one that 1%, only no confirmed cases were reported through inhalation-based precautions. Only one through droplet exposure was identified. So it is mainly through direct physical contact, both sexual and non-sexual.
Thank you so much. And I hope for our colleagues, we have understood that from the systematic reviews, 95% was mainly through direct contact. And I think as we progress into the next session, this is one of the key things that we need to understand the modes of transmission, which are informing this new guidance and recommendations. I have seen some questions on the chat box. I want to encourage you, let us use the Q&A for question and answers. And to those who have just joined us, we had said the chat box is only for introductions and the Q&A for the questions on the presentation, so that part of our team will be responding to those questions. And also we're also encouraging that you share the links within your networks so that they can join into this important session. And there's also interpretation available. You can just at the bottom there, you can select the French option. Okay, as we move into the next session, which is important because it focuses on the practical updates on the new recommendations, I would want to welcome Dr. April Bola, who's going to walk us through the key updates in the new recommendations. Over to you, Dr. April.
Thank you so much, Tendai. Can you confirm you can hear me well?
We can hear you and see you clearly.
Great. Okay. So first of all, I just want to thank you, Tendai and Afro, for the opportunity to speak today, and also to Dr. Solomon. I think that was an excellent opening and really set the scene. And Nasheen, thanks also for the, I think it's important, the evidence base behind the update of these recommendations. And finally, to all of the participants, I see a lot of names here of colleagues that we've worked together in the field, and really appreciate you taking the time with your busy schedules to listen in today. Okay, so with that, we'll move ahead. So we're going to be doing a deep dive at the recommendations. So the next slide, please. Yeah, so the highlights of the IPC recommendations. These recommendations and these guidelines are clinical management and IPC, but we're very much focusing on the IPC element. But of course, it comes as a package. And as you know, the pathway, the patient pathway, when they're coming into the health system, often starts with the screening and the triage. And just to say that we're not going to go into all of those elements, but to be aware that they're all a critical part of that pathway. So with that, the next slide, please. And here we have a scheme, and this scheme really is to kind of help us to walk through what do we do with the Mpox patient when they come, when they're actually seen. The first thing is to really assess their severity. Are they mild, moderate, or severe? If they are moderate or severe, then they should be admitted to a health facility or to an Mpox treatment center. And you can see that we ask here, is it high risk patients or is it severe or moderate? They admitted to the health facility. So that's a yes, and that goes to the left. If that is a no, then they're considered a mild patient. So from the severity side, they can then be managed within the community. Then you ask yourself within the community setting, what type of community setting is it? Are they living in the refugee camp? Are they living in IDP camps? Are they living in overcrowded settings, such as in a slum setting? And if that's the case, then they really should be managed within a community care facility. However, if they are living at home, then you have to go through there's some IPC questions, and we'll get to that later, on the conditions for them to be able to be managed at home. If that is the case, then once again, you can then consider, do they need to be isolated within the home setting? Or can they actually be managed where they can move around and be able to continue with their normal quote unquote activities? And they can do that as long as they can comply with particular measures. And those measures are covering their lesions and wearing a mask. And we're going to go more into that. So all of this is just an overview of what's coming. It's obviously quite a complex situation, but to go back to what Dr. Solomon said, we have to be innovative. We also have to adapt to Mpox moving from an emergency into the routine health system, and how can these people be managed when they really don't need to be going to specialized centers. Next slide. Next slide. Okay, so factors for decision on Mpox patient management as inpatients. So who are the ones that should be managed within the health facility? As mentioned, they're the ones who have severe disease or complications, a high risk of complications. And who are those? Those are children who are less than 5 years old, pregnant women, immunosuppressed, and people with chronic underlying comorbidities. Another group of patients are patients with clinical signs and symptoms of complications, such as really the patients that are showing some type of sepsis, so they could have nausea, vomiting, confusion, irritation, problems with breathing. They could also be malnourished, or they could show signs of severe disease through extensive mucosal lesions. And if they are in severe pain or have secondary infections of the lesions, all of these patients should be managed within the healthcare setting. Next slide. Now, as far as the IPC measures within the healthcare settings, so firstly, just to emphasize the importance of standard precautions. Standard precautions should be used for all patients at all times, at every interaction. In addition to that, you may have to use transmission-based precautions based on a risk assessment. So within the context of Mpox, we have here some of the key areas that are important to prevent the transmission, as was highlighted before by Nasheen, it's direct contact. So what are those specific measures? Hand hygiene, of course, patient placement. Patients should ideally be placed in a single room. We appreciate that that's challenging in many different settings. If it's not possible, then cohort confirmed patients. If you do have to cohort suspect patients, it's preferably that those are going to be the ones that are probable cases. You should really ideally have the suspect patients in a single room. And if you can't, then at least to keep the distance. As far as the PPE the health workers need to wear, we'll be coming to that next. Injection safety is critical. Environmental cleaning and disinfection should increase, particularly on high-touch surfaces. Transportation of linen, handling of linen. The good news is that the linen can be decontaminated either by washing by machine for 20 minutes with hot water and a detergent, or also with low concentration of sodium hypochlorite at 0.05%. Patients need to have their own personal medical equipment, which should be cleaned and decontaminated after use. And finally, any types of bodily fluids or waste from patients with Mpox should be considered as infectious waste. Next slide. So what are the actual PPE recommendations? And this is where the updated guidance has changed. Previously, in the interim guidance, it was advised that health workers wear a respirator. Now, after looking at all of the evidence and having a better understanding of the modes of transmission, the recommendation is for patients with suspected or confirmed Mpox. WHO suggests that the health and care workers should use contact and droplet precautions. So what specific PPE is that? For contact precautions, it is gowns and gloves, and for droplets, it is a medical mask, so no longer a respirator, and the eye protection should be based on a risk assessment. Of course, if there is a situation where the ventilation is poor, it's unknown, then a respirator can be used. And in any situations where we're doing AGPs, aerosol generating procedures, should also use a respirator. Next slide. So just moving on to the importance of visitors. Within the healthcare facility, it's important that patients do have contact with their loved ones. So visitors are encouraged. However, those visitors should perform the appropriate hand hygiene before and after exiting the patient room. And there should be consideration if the visitors are persons who have high risk, whether or not they should be visiting the patient. And there's also always to consider alternative modes of communication, such as the mobile phone and using the WhatsApp if that's available, or video conferences in certain cases. Next slide. So now we transition from the healthcare facility setting to the community setting. Once again, many and most probably all of you are very well aware of the preventative IPC measures within the community setting, what we call IPC in the community. And these are not only preventing transmission of Mpox, but many other types of infectious disease, and particularly waterborne diseases. So the importance of hand hygiene, and for Mpox, the dedicated personal items, irrespective of where they're being managed within the community, that they should have their own linen, emphasizing the also importance of environmental cleaning and disinfection, because there can be indirect transmission. And finally, the waste management that we discussed earlier. Next slide. So what are the criteria for home-based care? So persons who have suspected or confirmed Mpox can recover at home if the national guidelines allow, and if the following conditions are in place. So the person has to have been evaluated by a health professional, whether a nurse or a doctor, to ensure that they are confirmed as a mild, uncomplicated case. They also are able to manage their own personal care or have somebody who can support them with that they and the person who is going to support them can take can actually implement the IPC precautions that are important to prevent further transmission within the household. We heard Dr. Solomon speaking about the challenge of having many people within the household. So it's very important that if you do have them, you can implement these precautions. And if not, then you will need to isolate, as we will see later on, that there is sufficient and safe water to perform cleaning and disinfection, and access to supplies, mainly the PPE supplies, and that the patient can be monitored at home until all of the symptoms are resolved. And of course, that they are free from other risks that will make someone vulnerable to severe infections. Next slide. So what do we do about children who are over 5? Children who are under 5 are considered the high risk group, and they should be managed within the healthcare setting. But for children who are over 5 and less than, let's say, teenagers, what is the advice? The advice is that if they're unable to cover their lesions or tolerate wearing the mask, then they should be considered to be admitted within the healthcare setting. Also, wherever they are managed, it's important that they remain together with their caregiver. And any decision, of course, that's made about the child should be done in consultation with the caregiver. And then finally, irrespective of where they're housed, it's important to address their psychosocial well-being. Next slide. So some of the education that patients should be given when they're going to be managed in the home is really basic but important, that they should keep hydrated, they should get enough sleep, they should eat well, important to take the medications they need for pain, and if they have fever, that they should stay connected with others without risking transmission, exercise where they can, when they can, and also request for any emotional support. Next slide. As far as their rashes and lesions, it's important they don't scratch the lesions, that they clean their hands before and after touching them. Of course, the lesions are the area where the highest viral load has been identified with swabs that have been taken. So it's really important to be very careful on managing the lesions, to keep them dry and uncovered when they are alone. And if they need to, they can also use sterilized water when they're going to clean them. They should rinse their lesions in the mouth. You can rinse the lesions within the mouth with salt water that alleviates some of the pain. In addition to that, take warm baths with baking soda if they have that option. And then to use paracetamol for any discomfort. Next slide. So what is the new recommendation in the context of mild patients being managed at home? The new recommendation, which is a conditional recommendation, which means that certain conditions have to be met to be able to implement it, is that WHO suggests that persons with mild, uncomplicated Mpox lesions cared for at home are not required to isolate, provided that their lesions are covered and they wear a well-fitting medical mask when in close proximity to others until their lesions are healed. And this is what we saw on the flow chart at the very beginning. First, it's decided they can be managed at home, and then if they can comply with these conditions, then they do not need to isolate. And what does that mean in practice? It means that they would be wearing the mask, covering their lesions, and be able to walk around the household and also be able to go outside. And some of the advantage of this, which Nasheen wasn't able to go in from the evidence base, is that you're also taking into consideration the situation of the patient, their economic situation, if they have to go out for work, their mental health, and some of the social elements, and also the issue around stigma. If they have to stay home, then sometimes they can become stigmatized by some of the in the neighborhood. And of course, depending on where the lesions are, if they wear a mask and cover the lesions, then others may not even be aware that they actually have Mpox. So really, this is, once again, it's a nuance. So it's nothing is in black and white, but it's important to understand that this option is available under certain conditions. Next slide. So this is mainly what I was speaking to before. They should always wear the medical mask when they are near others. This is really about implementing the new recommendations. Ideally, follow up with a healthcare worker would be via phone. It's important that they clean and disinfect either them or their caregiver. Any frequently touched surfaces, clean and disinfect them regularly, at least twice a day. Whenever they leave the home, they should cover the lesions, wear the mask. And caregivers should keep a 1 meter distance. However, when they have to come close to them, if they're helping them with the cleaning and changing of linen, etc., then they should wear a medical mask and gloves. And one thing we didn't add in here, but is also that it's important that the person has their own personalized items, and this includes any utensils that they're going to be using within the household. Next slide. So for the home-based care, this is a package which needs to be implemented in the context of the community and within the bigger setting. What do I mean by that? Is that this is not something that the patient can do themselves. They have to engage community health workers to be able to support them. They will also be the ones that will come and see them. They will monitor them. And really be providing them with psychosocial support in addition to following up how they're doing. So it's important to engage community health workers and for them to be a part of this whole package. And they will also be the ones that will promote the cleaning and to repeat some of the critical instructions with respect to infection prevention measures within the home. Next slide. Monitoring, as was mentioned before, they should have regular visits, and this can either be weekly or more depending on the case and how much support is required. And other persons who are in contact, so it's not just monitoring of the patients, but household members who are in contact, they should also monitor themselves for developing any signs and symptoms, and that should be for a minimum of 21 days after they have last contact with a person with Mpox. Or once the person with Mpox is declared that they no longer have it, then they need to continue monitoring themselves for 21 days. So that's any other household members or other contacts. Next slide. So what are the conditions for ending the home-based care? Whether they're isolating or they're not isolating, patients recovering at home, as stated here, should refrain from close contacts with others until their skin lesions have crusted, the scabs have fallen off, and a fresh layer of skin has formed. So once that has happened, they are considered no longer infectious and that they no longer have Mpox. Next slide. So how to end the home-based care? This would be something that should be recommended by the local health professional. And once they have recovered, then they need to do a thorough, almost what you could call a terminal cleaning, disinfection within the household of all the high-touch surfaces, the utensils, the bathroom, the linen, the clothing, and the mattress that has been used. So once that's been done, then it can be reused. Important here that nothing needs to be burnt. Next slide. So key take-home messages around home-based care. Individuals with mild Mpox can be managed within the home settings as long as they cover their lesions and wear a mask when in close proximity to others. However, if they cannot comply with these, they can still be managed at home. However, they will need to isolate. Or alternative, as was mentioned at the very beginning, if they're high risk, they would be managed within a healthcare setting. Close contact with others should be avoided until the person has fully recovered. And that is what we were saying earlier about the lesions have crusted and they have new skin. And health workers, including community health workers, may play a role in the home care. They should be trained and also have the appropriate supplies and measures to be able to provide care in a stigma-free way. So thank you very much. And with that, I'm going to hand over to Nasheen. So the next slide, who will speak to the context of IDP camps, managing patients within crowded settings. So next slide, and over to you, Nasheen.
Thank you so much, April. So this is the draft document that we have developed in consultation, in collaboration with UNHCR, IOM, UNICEF. And this was initially requested from the field based on the needs and the requirements that we have seen, that it's very difficult to implement home-based care in the IDPs and refugees settings. Even the updated recommendations, as it suggests that no longer we need isolation if the patients can comply with mask and cover their lesions. However, it is very difficult to comply with the recommendations if provided that IPC measures are very difficult in overcrowded to implement in overcrowded settings such as IDP and refugee camps. As people share their bed space, their living space with living within a small tent with 6 to 7 family members. So based on these challenges, we have come up with several principles, which includes the IPC principles as well, but it has several components leading starting from the planning and coordination phase till the implementation and monitoring phase. So from the planning, the first stage is the planning and coordination, which is required to establish the community care centers for these settings. It needs, the first step is to map needs and you coordinate with the camp shelter focal persons and also with the incident management teams. Why? Because we need to determine the bed capacity within the community care center based on the estimate of the burden of disease in that targeted community. Also, we need to engage affected communities early in the planning phase and throughout the implementation, because we need to get their feedback first on the accessibility and also the essential healthcare service that they would require, and also their voluntary admission to these community care centers. So that's for that reason, we need to ensure that there's proper community consultation, and it should be two-way community communication, that we get their feedback and also incorporate it into the planning design phase. And then we also need to consider involvement of integration of other sectors such as shelter, food security, nutrition, and protection, because some of these affected person with Mpox, they need to get their food from the food distribution points. They need to get their based on their economic situation, they need to get some resources for their livelihoods of their family members. So we need to coordinate all these with other sectors. The second phase is, once we have the planning coordination, is the eligibility and admission criteria. We need to consider only the individuals with, as it's the criteria is same as for home-based care, as April has mentioned in detail, that are mild, uncomplicated Mpox, which do not require hospitalization. So community care center is exactly the same as home-based care, but it's for the IDPs and refugees and overcrowded slum areas. And this decision have to be made by clinicians using the established case definition and referral pathways. We need to consider the fear and stigma and mental health needs, because these affected people, once they need to, and it should be well informed that what is the disease and what are the admission criteria, so they can well reintegrate after once they recover from the disease back into their community. So we need to consider all these psychosocial vulnerabilities of the affected persons. Next slide, please. The third, this is not the third phase, but it is this is another consideration why during the planning phase that we need to consider that each patient should have dedicated room. But if it doesn't allow, the resources do not allow to have dedicated room, then we need to cohort confirmed cases only, just to make sure that it is for confirmed cases only. There should be no admission to the probable or suspected cases. And there should be 1 meter distance between the beds. Separate toilets should be available as well as showers for the patients, with increased cleaning and disinfection, with increased frequency of cleaning and disinfection procedures. There should be dedicated space for caregivers with safe overnight stay options in case they need a caregiver from their home. There should be a proper ventilation within the center, and also we need to make sure that it includes safe storage spaces as well as cooking, laundry, and communication facilities. The IPC principles, the first one is that we need to consider is that strict hand hygiene. We need to consider and promote by using community healthcare workers through proper educating the patients as well as the caregivers and the healthcare workers. There should be PPEs available for healthcare workers, caregivers, visitors, as well as for the patients, because if they can cover their lesions and wear masks, they are free to allow and move around the space within the community care center, or if they want to go out. And then they should be also, they can do the cleaning and disinfection protocols for all surfaces and shared facilities. Depends on the resources that can be established. Either they can be done by the patients themselves or by the cleaner, which is dedicated by the camp management facilities. And then we need to make sure that there are safe laundry services available with also supplies availability. And then make sure that all the waste, the PPEs should be desegregated in color-coded waste bins, and there should be proper safe storage space available for the waste, and there should be also treatment and disposal facilities available within the community care centers or off-site. Next slide, please. The other important, no, please, previous one, is essential healthcare. The previous slide, please. The essential service. It is previous, yeah, this one. So essential services that are required, and it's where to run and operate the community care centers. First is that safe water availability for hygiene, cleaning, drinking, and for all the and for cooking, laundry purposes. So these are the amounts that has been established for community care center, and also there should be latrine, toilets available for the patients, and hand hygiene stations. Food should be made available, cooking utensils, as well as nutritional support to the affected patients as well as for the caregivers. Sleeping spaces should be provided with beds, also mosquito nets. It's very important because in areas with vector-borne diseases prevalence, so this is important to consider. Hygiene supplies, soap, PPEs, menstrual hygiene products for women. Also, we need to consider the gender aspect while determining the bed space, as well as allocating the space for the affected patient. So we need to consider that while we design the community care center. And we need to, as April has also mentioned, psychosocial support is very important. Also, recreational activities for the affected people, because this will help them to comply with the IPC measures. Otherwise, it's very difficult to confine them for 21 days in community care center. And also, it's important to make sure that there are referral linkages available to health services for even if in case the patient condition deteriorates. The staffing needs, which we need to consider, is that minimum staff that is required for the community care center is the manager, the community liaison officer, the security person, cleaners, as well as daily health visitors, which can be community health workers as well. Trains community healthcare workers should provide health education, also psychosocial support, and also get the feedback from the patients that what are their needs and if their needs have been met and how they are complying with the IPC measures. So act as a link between patients, families, and communities. And then the social workers need to help the affected patient once they are discharged for the reintegration back into the communities. Next slide, please. The community engagement protection is the backbone of establishing the community care center because they provide a close linkages, also raise awareness within the communities, and also address the stigma, discrimination, misinformation proactively. So they can use different channels within the IDP camps or within the targeted areas, and also safeguards the vulnerable groups' needs and address these through community consultation and engagement, and bring back that feedback into the camp management or community center management managers. And then the other important area that, though we have established the community care center, is the monitoring and continuous improvement, which can only happen through regular visits, conducting safety audits, getting feedback from the patients, caregivers, and communities, and also monitoring the adherence to the IPC measures, because if they are not applying the IPC measures, it would not be useful to establish this community care center. So this is very important to monitor it regularly and adopt operations-based lessons learned, and also based on the evolving needs, consider these operations accordingly. Over to you, Tendai. That's all from my side.
Thank you very much, Noshin, and thanks also to Dr. April for the detailed presentation on the new recommendations. You guided us through the patient management, flow and clinical pathways. You also highlighted the key practical measures for healthcare facilities, emphasizing on the contact and droplet precautions, the careful consideration in the type of PPE to use, when to use the medical masks, and the special cases where there is poor ventilation and when doing aerosol generating procedures where you can now use the respirators. I think you also emphasized on the key measures for home-based care, which included mask use, lesion covering, daily cleaning, and also multiple ways of following up with patients to ensure adherence. And equally important, Noshin, what you've shared on the special considerations for the IDPs and informal settlements over crowded settings. So with that, colleagues, I think we can now proceed to the polls for this set of presentations. May we have the questions for the presentations? And I'm going to request the interpreters to please translate to French as I'm reading through for our French colleagues who have joined in online. So here again, colleagues, we are going to select, it's a multiple choice. We are going to select the appropriate responses. The first question, please select the implementation consideration of home-based care from IPC perspective. The first response is wearing and cover their lesions. Second one, hand hygiene. Third, environmental cleaning and disinfection. Fourth one, dedicated personal items. Fifth one, linen and laundry management. The next one, waste management, or all of the above. Okay, may you please select the appropriate response for this first question. Moving on to the second question. In patients with suspected or confirmed Mpox, who suggests that health and care workers use contact and droplet precautions? Please select the personal protective equipment PPEs required for conduct and droplet precautions in the following: gloves is the first response, gown, medical mask, eye protection based on risk assessment, or all of the above. The third and last question, multiple choice question, only use the respirator when ventilation is poor while performing aerosol generating procedures or based on risk assessment, for example, for immunocompromised patients or where there is presence of mucosal lesions. Is this true or false? Kindly respond to those questions as well. I think I'll just give you a few seconds for you to respond. And also to reiterate that we can still use the Q&A for questions that we have on the key recommendations that have been shared by Dr. April and Noshin. Thank you so much. So the responses, I think you can see them on the screen. I think 80% said all of the above to the first question. Then to the second question, on the contract precaution, 76 agreed with all of the above. Then on the next question, only use respirator when ventilation is poor. 72% have said it's true and 28% said it's false. So I don't know, Dr. April, if you want to take them through, I think the first and the third question, just to emphasize on what the recommendation is on those two issues.
Yes, thank you. So they were correct, the majority. I'm sorry, I think I just on
the 28%, we are still saying we use respirators.
Yeah. So I mean, I think for this one, there's the recommendation, which is basically what was put there, which is that they should use the respirators in the context when ventilation is poor, it's unknown, when they're doing aerosol generating procedures. However, health workers do have a choice. And I think we need to keep that into consideration, even though the recommendation is the medical mask. There will be health workers who want to use respirators irrespectively, and that's also acceptable. But the recommendation is that because the mode of transmission here is close contact, and potentially a droplet, and there was no indication of inhalation, the medical mask is sufficient. I hope that clarifies, Tendai, but let me know if not.
No, thank you so much. I think that's very clear, and I think all the I can see thumbs up reactions from participants that they can clearly understand. Colleagues, continue to use the Q&A, and we now move on to the next session where we are also now going to hear practical experience from the ground, how Zambia has been doing it with regards to implementing home-based care. With regards to patients with Mpox. Over to you, Mr. Innocent. Welcome to the session. Thank you.
Good afternoon. Thank you very much, Tendai, and thank you very much to everyone who has joined on the platform. I must apologize that I'm unable to show the video. Got a challenge with my computer. Having said that, allow me to go to share on an experience of how managed strategy for our country, Zambia, in the area of Mpox next. Next, my name is Innocent Hamganyu. I'm the Chief Environmental Health Officer from Zambia. I coordinate IPC as well in the country. Zambia has a function IPC program which flows from the national level to the community level. In between, we have got the regional and also the district healthcare facilities. Under the IMS, the IPC program falls under the operation pillar of the response. So it's also worth to mention that IPC program has a subcommittee which meets every 2 weeks and is composed of Ministry of Health, partners, and also various line ministries, including WHO. Next. Next. So this is how the structure is established for IPC. We have the Ministry of Health, which is an umbrella of the healthcare systems, which deals with the policy and resource mobilization. The principal officer being the permanent secretaries. We have 3 for technical administration and also to coordinate the donors. And also we have the provincial health offices. Under the IPC and the ministry, we have also the Department of Public Health and Environmental Health according to the law of the nation. They coordinate the IPC. Furthermore, from the from the province, we have the district, the healthcare facilities, and the community who deals with the issues of the IPC at all those continuum of care. Next. Next. So allow me also, colleagues, to give you the AP overview of the current situation. Our report as per week 37. We stand at suspected 123, current in admission, there's 0, confirmed, we have confirmed 25, 27 active cumulative, we are standing at 274 with 3 deaths. And also in our country, this was declared monkeypox on 10th October 2024. And up to date, the data represents the cumulative numbers. And as we speak now, we still record some more cases, and we stand at 271 cases as of September 2025. Next. So the mode of is through the contact. So this is the monkeypox, what we do. Age range is between 2 to 78 years. Next. And the kits which we use for PCR is as indicated as follows. We can go next. So the assessment of a monkeypox risk in Zambia, we have the risk transmission into Zambia is considered high. The likelihood of in-country transmission is classified as moderate. The potential impact of a monkeypox outbreak in Zambia is assessed to be high. The overall risk, considering the high probability of transmission and significant potential impact, the overall risk of monkeypox to Zambia is deemed high. So this is how we have assessed our monkeypox risk in the country. Next. So when you talk about the monkeypox transmission, we have got indirect transmission. We have got also vertical transmission. Under the indirect, this is, for example, through the clothing, linen that has infectious skin particles. Then also, if shaken, these particles can disperse into the air and also be inhaled or land or broken skin or mucous membranes and can lead to transmission of infection. Under vertical, we are talking about during the pregnancy, virus can cross through the placenta and also causing exposure to the fetus and complications such as fetal loss or stillbirth and conjunctival infection of the infants. Next. So the treatment, each facility has designated isolation facilities or isolation facilities, and also to limit the health infections, trainings and mentorship are ongoing, including the staff and also the community members. Next. So key management steps, we are talking about supportive care, management of skin lesions, arising complications, and also pain management. Also IPC as the subject matter for today, and also check for other sexually transmitted infections. And we consider also effective antiretroviral for severe cases. Next. We can go next. Next. So during the contact monitoring, we monitor closer contacts for 21 days after last exposure, and also individual exposed to monkeypox virus can continue their routine daily activities. For example, they can go to school, can go for work, as long as they do not have signs and symptoms or persistent with monkeypox. Next. So the home-based care as the case of Zambia. As I've already talked about, we have got also monkeypox clinical evaluation, which is mild and moderate. We have got also a criteria for selection of patients for home-based care. And also we have got there also the care for patients on health home-based care, then follow-up of patients, and then also guidelines when to return to health facilities or home inspections for the cases of issues of the infection prevention and control. So that is the criteria which we use as home-based care for the case of Zambia. Next. So what is the rationale for home-based care? We are looking at preventing transmission, that is isolating infected individuals at home, helps prevent the spread of the viruses to other communities, and also resource mobilization or resource management. We talk about health home care, reduces the burden on health care facilities, allowing them to focus on severe cases and other critical health needs, and also continuum of essential health services. Then the other thing is accessibility. In resource limited settings, home-based care provides a practical solution for managing Mpox, especially when the healthcare infrastructure is inadequate, as the case of our country. We don't have so many isolation facilities. So the home-based care becomes key and more practical for us to manage the patients. And also supportive environment, being at home can provide a more comfortable and supportive environment for recovery, with family members be able to assist in terms of care. Next. So I continue also criteria for Mpox home care and isolation. We have got also what we call clinical factors and also environmental factors. Under the clinical factors, we are looking at the mild and complicated Mpox may be isolated at home. The decision as whether to care for a person with Mpox at home depends on the following key factors, and among others, we look at clinical evaluation of the person with Mpox. There's also an established mechanism to monitor the disease progression of a person with Mpox at home. The third one, the ability to maintain necessary precautions to prevent onward transmission in the household, and access to sufficient safe water supplied to perform cleaning and disinfection, personal hygiene and supplies, sufficient to mitigate the risk of transmission to caregivers and household members. Please also, you must note that home-based care for pregnant mothers, infants, and children under 5 is not recommended. This should be done on case-by-case basis with strict follow-up with the healthcare workers. So for environmental factors, also we are looking at also issues of the health facility, treatment centers, and other settings with the isolation facilities. If the condition of the person with Mpox deteriorates, we encourage that they contact the local health care facilities authority. And also another criteria for certain individuals like children, pregnant people, immunocompromised individuals, and people with chronic skin conditions usually need care in the healthcare facilities. So those are excluded from the home-based care management. Next. So all cases should have initial symptoms of survey done, and these include foreign symptoms, which go up to 16. Issues of fever, we have to look at it if it's there. Is it mild, moderate, severe, rash, sore throats, all these conditions, diarrhea, secondary infections, confusion, seizures. That is the initial cases how we should have initial symptom survey for us to consider for the home-based care. Next. Next. So also, and with a continuation of all cases should have initial symptom survey done. Also, you include the following information. Document total number. If yes, you track it with each subsequent visit or contact. And also we look at patients with any of the above symptoms that are immediately escalated to the healthcare facilities for further triage. Also, we look with patients with 2 or more moderate symptoms should be escalated as well. A patient with confusion seizures should be immediately escalated. And any patient who develops sudden onset of weakness or difficulty speaking should also be immediately escalated. Next. So for inspection and also documentation of household living, these are certain conditions which you look where the environmental health practitioners also take cognizance of this. We look at how many people in the household. Is it a single home, family home? How many rooms at that particular household? We look at if there's a room for patient to be isolated, if there's a space well ventilated, and also we look at issues where we look, is there any elderly person in the household? Then we also look at it with the following household with the skin conditions of any type of hypertension, asthma, diabetes, HIV, and also central nervous issues, respiratory conditions, and also we look at if at all there's someone available to attend to the patient. Then also look at conditions such as, is there any common toilet used by multiple people? Also, we look at issues of does the primary health care have DM, asthma, hypertension? So if these following questions are answered, then you'll be able to determine the household if it can be used as a living condition for the home-based care. Next. So for mild cases per assessment, which are deemed to have living conditions for self-isolation, we look at the daily check via the phone or video or in person. Also do the repeat of symptom survey. Then also we look at, we note also any sign of improvement or resolution of existing symptoms. We look also, we take note of all symptoms that have been resolved and recommended or discharged. Also, we evaluate and provide information also for issues to look at also sourcing for essential or palliative medication for patients. Then we encourage hydrations and also reinforce principles of infection prevention and control. And also the ninth one, we look at if any member of the household has developed any symptoms. So all these are Mpox case, and also we interface with the community health workers. Next. This is just a community health patient home visit follow-up. We look at the practice standard for IPC, where we also encourage to wear the mask at all times. Also, we look at the hand hygiene issues of washing hands with soap, continuous assessment of patients' living conditions if they have changed. Also, we assess the accuracy of the severity of the patient's symptoms and observe other members of the household exhibiting symptoms. Next. So also we calculate a sense of patient education, when to return to the healthcare facility, where we look at also what I've talked about, issues of the environmental factors, if there's change in the environmental factors, such as water supply, washer conditions, availability of cleaning materials, supplies. We look at household occupants change with high-risk population being involved. Next. So this is part of the checklist for walkthrough assessment of the home. I think I've already looked at it where it is well defined. Issues of the hand hygiene, PPE, decontamination, issues of isolation facilities, issues of the cleaning and waste management. Next. So under adequate information sharing and IPC education to the patients and family members, we take steps also to prevent the infection from spreading to other people with whom they may come in close physical contact, especially the household members. And also we encourage to stay in a separate room. Issues of the hand hygiene regularly with the soap or alcohol-based hand rub. Issues of using communal toilets and showers. And also we discourage to share the bed or sleeping area with other people. We avoid also sitting on shared household benching. And also we look at also only one person from the household should provide the care to the patient under the home-based care. Next. So this is another criteria I was talking about, where we do the assessment for the mild and low risk, the rapid response teams accessing the isolation, where we assign the community health worker to each case, designate them under respective catchment area. We look at also issues of non-adherence to home isolation and IPC measures, and also conditions that deteriorate while on home isolation. Remember, on the health home isolation monitoring of cases, household contacts are ongoing, IEC, IPC, and schedules for the lab test. And also we interface with the healthcare facilities in terms of the case management for facility isolation. Next. So what are the lessons learned under the home-based care? Is that the home-based care has lessened the burden on the healthcare providers. We know that every country is gathering in terms of the surge capacities, in terms of the numbers to manage the cases at the facility. So it creates also a space for inpatients and also infrastructure. The other thing is that existence of 4-tier health systems allowed the isolation of patients to be managed with no difficulties. Another lesson is that no new cases were received from the homes where isolated patients were managed, from compared to the initial cases that the country recorded as new cases that were contacts from the facility or family members as index. Another lessons we learned under home-based care is that the mode of community sensitization on IPs at household level, as community members where community members were allowed to visit the patients with caregivers providing the IPC guidance. Also, issues of the fear, stigma among the community members, I think we managed that thing. Then skills and knowledge transfer and management of Mpox in the community also has been the positive things, what also has worked well in terms of the community and home-based care management. Next. So, of course, out of the main good things about the home-based care, issues also of challenges that they arise, such as limited resources to pay the CPAD to the community health workers, issues of the allowances, motivation, also issues of the IPC commodity supplies to the household to facilitate with IPC compliance. So we intend to run short of these commodities to replenish the community. And also these IPCs, they also range from issues of decontamination, disinfection, and also supplies for the IPC in totality. Next. In conclusion, I think IPC has worked very well for the country and also would encourage our member state to take leave what we have done as a country, what we have done best for the country, and also we can offer technical support and also lessons from what has worked well under home-based care. I submit. Thank you very much.
Thank you very much, Mr. Innocent and colleagues. Maybe we can react a thumbs up or an acknowledgement of Minister Innocent Amganyo's presentation from Zambia. Thank you for sharing this rich and detailed experience in implementing home-based care. And I think your experience gives us a clear picture on how well structured national IPC program with coordination at the national down to the province, districts, facility, and communities can make safe provision of care within their communities and at home possible. And also the rigorous checklist that you shared with us, which we're looking at specific components on IPC to make sure that even at the you are providing care at home, the environment is enabling, and the patients and also the caregivers and the family, they are able to adhere to the IPC standards. So indeed, thank you so much for such an enlightening presentation. Also, you touched on community engagement, on also how they played a key role in supporting home-based care, which is quite instrumental. So colleagues, I want now to open the question and answer section. You can use the raise button option and you'll be enabled to unmute your microphone so you can ask questions. So colleagues, I'll be looking out for any hands raised, but as we wait for that, for the hands, I think I saw some questions on the chat, which I'm going to ask Mahmoud, Dr. April, and Noshin if they can respond to. I think the other question Noshin already responded to in chat, but maybe she can speak to it so that other colleagues can hear it if they have not seen the response in chat. There was a question on what is the procedure to manage infectious waste in aspect of home-based care. And while you are responding to that, maybe you can add the other question that was just put in the chat on how to decontaminate instruments and what chemicals we used. Over to you, Noshin.
Thank you so much, Tendai. So for waste, I've already responded that the waste generated during the home-based care, which is PPEs, mask, and gloves, or other material which is being used by the infected patient, like bandages. So this should be considered infectious and it should be disposed of in a closed, tight bag. We should keep it away from animals and either close it in a tight waste bag or directly bury it and at the site. If it's difficult to do it on regular basis, then it would be good if the municipality services are available to collect the waste bags and also dispose of with the municipal waste. So this is, but we should focus on the rational use of PPEs that even for the caregivers and all by the patients who are using PPEs, that we should adhere reusable PPEs, or so it can be the waste that is generated at household is limited. Back to you, Tendai.
Thank you very much, Noshin, for that response. I don't know, Dr. April, there was a question how to decontaminate instruments and what chemicals we can use, which was also posted in the chat. I don't know, April. Colleagues, if there are also questions to the presentations from Zambia, if you have questions, you can raise your hands.
Yeah, thanks, Tendai. So I think the take-home message here is that this is actually a virus which can be relatively easily inactivated. There has been some studies done in publications. I don't know, Nasheen, if you can put them in there, which showed that yes, that this is the case. And so really what we don't have specific guidances on it, except to say that whatever the health facility is using, they can continue and use that, and just the normal procedures for disinfection and decontamination and sterilization based on what type of medical equipment is and what type of what level of disinfection that it needs. So it's nothing specific for Mpox. And as we were mentioning before, even for the laundry and in the linen, they can use an 0.05%. That's what's been found. So just to say, it would be your normal standard precautions and the normal whatever there's already being used in the health facility. I hope that's clear, Tendai.
Thank you so much. I think it's very clear. Colleagues, I don't see any hands, but I see there are 2 hands that have been lifted. I think if we can help by unmuting them. Aditi, there are 2 hands. There's Sage. Sage, over to you.
Je prends la parole?
Oui.
Oui, merci. Très bien pour la présentation de Innocent de la Zambie. C'est vraiment très illicite. C'est très clair et explicite. Mais j'aimerais connaître les précautions que la Zambie prenne avec les Mpox, connaissant que, entre guillemets, là où se trouve le Mpox, le virus d'Ebola est quelque part dans la nature. Quelles sont les précautions que la Zambie prenne, connaissant que derrière le Mpox, il peut surgir une épidémie de MVE, de la maladie à virus Ebola? Quelles sont les mesures que la Zambie prenne pour contourner un peu à ce qu'il n'arrive pas à être surpris comme a été le cas en RDC avec Ebola à Boulapé, alors qu'il y avait l'épicentre même de cette maladie non loin de là. Merci.
Merci, Saj. C'est une bonne question. Tanda, do we have the translators for, it's for Zambia, for Dr. Innocent, if you can quickly translate it.
Mr. Innocent, I don't know if you understood the question was for Zambia. They were asking what precautions you are putting in place to prevent the transmission of Mpox, and also considering that I think here the message is that although both conditions are of zoonotic origin, I don't think it necessarily means that they are at risk of Ebola, but Zambia bordering Angola, sharing some parts, bordering DRC, sorry, what are the measures that you're taking to prevent or to be ready for Ebola virus? Mr. Innocent, that was the question for you.
Thank you very much, Tendai, and also the colleague was asked the question. The first and foremost, what we are doing as a country, we are doing the risk assessment across the regions which are bordering with DRC. We are also looking in terms of all the pillars, the points of entry, IPC, case management, risk communication and community engagement, the laboratory capacities, and also if these facilities which are near the border area, if they have got the isolation facilities. And also we are looking at also the workforce development. We have enough such capacity. We have the issues of the PPEs. We have adequate water supplies should we record. So all those are the things which we are also looking at in the primary risk assessment. The second one, we are doing the capacity building. Also, we are training the workforce across those bordering areas. So the trainings are ongoing. Then also 3, we also strengthening our lab capacities, looking at One Health concept. So those are some of the measures which also we are also doing. And also we have raised the bar in terms of the screening and detections at the points of entry, and also among the truck drivers, and also the high-risk population. So what we are doing is a collective and working in the multi-sectorial. So those are some of the issues which we are doing as a country. I submit.
Thank you very much, Mr. Innocent, for that clarity. I think quickly the last 2 hands that are raised, there is Aweru If you can please go ahead quickly so we conclude the session.
Merci. Bonsoir, je ne sais pas si vous me recevez bien. Alors, moi j'ai une question par rapport à la présentation de la Zambie. S'agissant des mesures de contrôle dans la communauté, particulièrement pour le transport public. Je ne sais pas s'ils ont le même système de transport que nous. Et moi, je vous appelle de Lomé, c'est au Togo. Ici, nous utilisons largement des taxis-motos. Donc, il s'agit des motos. Donc, ils sont utilisés par des transporteurs qui peuvent transporter dans la journée jusqu'à une dizaine, voire une vingtaine de personnes. Donc, en utilisant le même casque. Donc, le casque est utilisé pour un client, ensuite il est passé à un autre client, ainsi de suite. Est-ce que vous êtes confronté à ce genre de difficultés là-bas et comment vous gérez l'utilisation des casques ou bien de motos par les mêmes usagers? Parce que vous avez dit dans votre présentation que les personnes qui ne nécessitent pas un isolement à domicile, ils peuvent aller et venir à condition qu'ils respectent certaines consignes comme le port de masque. Qu'est-ce que vous avez fait par rapport au transport public en ville? Est-ce que vous avez bien reçu ma question, s'il vous plaît?
Oui, merci, je crois que c'est bien. Innocent, Dr. Innocent, did you get the question? It was for Zambia. Or do you want someone
Someone
to
interpret for me from French to English.
Yeah, so he was asking, the colleague was asking about the, the public transport system in Zambia, and he's speaking from Togo and saying that the public transport are using these taxi motos, motor taxis. And one of the challenges potentially is if you have the helmet and then what do you do if you have to share helmets between the motor taxist and maybe a potential patient? So just, I guess the bigger question is, how do you manage suspect patients or confirmed patients in the context of when they have to use public transport? Over to you, Dr. Innocent.
Thank you very much, moderator. What it is currently, we screen these patients or suspects. Usually, the government offers the ambulances. We use the public ambulances most of the time when there's a case. So in that particular case, there's huge investment in terms of the public transport coming from the government to reach out to the suspects. However, in the event that the suspect has used the public transport, we take all the precautionary measures in terms of the infection prevention by disinfecting the vehicles and also assessing the driver was driving that and the like. So we take overall issues of the infection prevention highly, and also, as I've already talked about, issues of the follow-up intermittently for the period of 21 days to ensure that it doesn't develop any symptoms and the like. So there is that enhanced risk communication and also communication at all levels between the community member and also the healthcare facilities. So that is the interface which is there. Thank you.
Thank you very much, Innocent, for that clarity. And I think the key message is community engagement here to ensure that everyone is sensitized on the modes of transmission and also how to keep themselves safe as service providers, as people provide transport, and recommendations also on cleaning their equipment as well. There was another question, I think, from, I think, Dr. Avotri, I see your hand is up. Over to you.
Great. I was just trying to maybe offer some guidance on the use of the motorbike for suspects. I don't know whether it's evidence-based, but I was thinking, is it possible to educate patients in case of using a motorbike where they have to share the helmet and the rest to cover their hair whilst doing that? Is just a suggestion I wanted to put forward. Thank you, and over.
Thank you very much, Dr. Avotri, for sharing that. And I think I don't know if there's any evidence to support that, but I think it could be a practical measure which can be used. But I think the recommendation on the care of the equipment also would be quite instrumental in terms of cleaning and disinfecting after each contact with patients or any suspect, and also just emphasizing on community engagement, making sure that all the people have the important information. And if they see suspect cases, I think the issue that April emphasized in her presentation on covering their lesions as well, since the mode of transmission is through direct contact. I think the last two questions, so we conclude. Luciano, I don't know if Abdullah had spoken. Maybe quickly, Luciano.
Good morning. Thank you very much. I'm Luciano. I'm from Cape Verde. I would like to say that the presentation were very, very good. I have a question. We are here in Cape Verde trying to not having cases of Mpox, and I would like to hear about the other countries, what they did to prevent cases, and how if now they know if there was some mistakes they have done since the start of the disease, and if they could do it different, how could they do? And how can we prevent cases in the community when we taking care of patients at home, and how they in Zambia, how they did to prevent the other members of the families, how to not have Mpox and to prevent the spread of the disease in the community. Thank you very much.
Thank you very much. I think with regards to that, I think Mr. Innocent in his presentation, he indicated that initially at the beginning of the outbreak, there were contacts to the indexed case who were in the same household, and following which they had to institute a package of services to support the implementation of IPC and compliance of care within the home environment, which included uh, the criteria, the strict criteria that he presented on assessing whether a patient is fit for home-based care or not, which is one of the key measures. And then the second one, the environment that he mentioned, the checklist that they developed, which was assessing suitability of adherence at the home, which included the looking at conditions, availability of space to isolate, overcrowding, ventilation, the availability of PPE, suitability of the caregivers, and many others, and also community engagement. I think that's what he emphasized as one of the key things that they did to prevent transmission within the community as well. And I think with regards to other countries, I think the situation has been evolving with regards to reporting of new cases. And I think it's been a package of interventions, which includes enhanced surveillance, case management, and also lab capacity, being able to sequence and test all the cases. I think, April, I don't know if you have any additions to this.
I think you summarized it very well, Tendai. Nothing to
Yeah,
add.
thank you. Abdullah, lastly, before then we close the session. Abdullah, over to you. You can unmute. Yes, thank you. If you're talking, we can't hear you, Abdullah.
Can you hear me now, Tinda?
Yes, we're loud and clear. Go ahead.
Okay, very well. Very briefly, the question I had during the Mpox legion, presented in the
Abdullah, you are not very audible. Maybe try to move so we can hear you.
Okay, what
Or
of
closer
now?
to the mic.
Can you hear me now?
Not very clearly.
What of now? I changed my direction.
Yes, now it's clear. Now it's clear.
Okay, very well. Okay, briefly, what I want to know or to have insight is during the presentation, I heard that Epsom salt or baking powder can be used in order to give patient birth for the management of Mpox lesion. So I want to know the scientific rationale and also the pharmacological effect this has in terms of management of Mpox lesion. Thank you.
I don't know, April. I'll hand over this one to you. I had not picked that up in the presentation.
Yeah, thanks. Nasheen, you put the reference, didn't you, for that one? Can you speak to it? Because, yeah, I think it's coming from the clinical management, but
These are from the clinical management, and I have incorporated it. So these were also part of the Nigeria guidelines, and it has been implemented in several countries like US as well as Australia. So they have recommended it for using salt. So I will share the other link as well where they can refer it to. I'm not sure about the pharmacological effect of it, but I can share why they have recommended it.
we can also follow up with the clinical team, Tendai,
Yes. Yeah.
and get back.
Yes, definitely. Yes. I think as we share the resources to this training, we'll try to ensure that the recommendations on that will also be shared. So colleagues, I think we are about to close now. We've gone above time by over 26 minutes. So I'm going to kindly request if it seems there's a burning question. Please, I would like to make a question that I missed in my intervention. Maybe you can put it in the chat box as Dr. Solomon is concluding. For the remaining questions, we can quickly be interacting with you in the Q&A. Kindly put the questions in the Q&A. Dr. Solomon, I'm kindly requesting if you could please close the session.
Thank you very much, Tendai. Thank you, colleagues, for this very interactive session and the facilitators for making this happen. Before the closing remarks, I think the following are the key actions that are proposed by the group of the facilitators for all the participants to pay attention to. The first one is the need for the national adaptation and dissemination. Countries should adopt and adapt the new WHO living guideline on Mpox IPC and clinical management into national and facility protocols. I think this is very crucial. As you have heard during the presentations, we have really to bring in country specifics, and that adaptation is very crucial. The second one is training and capacity building. We have to organize orientation sessions and refresher trainings for health workers, community health workers, and caregivers to ensure correct implementation of the new recommendations. We have been talking about during the opening and also during the sessions that there is a need to move from an emergency response to transit into integrating into the other programs. And this cannot happen without having proper capacity building. So a continuous training and capacity building and orientation will be very crucial. Then, of course, the third one is the integration into regional systems. We have to embed Mpox IPC measures within existing national IPC programs, primary health care, and outbreak preparedness plans, so they remain active beyond the emergency phase. The other important point, the fourth point, is the home-based care support. You have seen, I think, even during the presentations and the lessons as well, the existing health facilities might not be able to cope with the increasing number of cases. And it is also sometimes unnecessary to overburden the existing health facilities. So strengthening the community-based follow-up and providing households with clear instructions, starter IPC kits, and risk communication materials to make home care safe and practical will be the other important aspects that we have to look into. Then the final point is monitoring on continuous update. Use the living guideline approach to review new evidence and update national guidance regularly, ensuring timely incorporation of emergency recommendations. I hope these are the 5 important key actions that we expect as you go back to consider. And maybe next time when we meet, we might be able to see where we are in terms of implementing these action points. So, dear colleagues, today's discussion have made it clear that ending the global emergency does not mean the work is over. Our shared responsibility now is to turn these recommendations into action by adapting them to country realities, supporting frontline implementers, and maintaining the momentum to control Mpox while strengthening routine health systems. On behalf of WHO and all our partners, I would like to thank you. And I would also like to thank the facilitators and the speakers, the participants, the members from the member states, and participants from the different other organizations, if they are if they have attended, for your active engagement. Your continued commitment ensures that the progress we have made against Mpox will translate into stronger, more resilient infection prevention and control systems for the future, not only for Mpox, but also for other communicable diseases. Thank you all for joining, and we look forward to continued collaborations as you roll out these important updates in your respective countries. Stay safe, stay connected, and let's keep working together to protect our communities. Thank you very much.
Thank you very much, Dr. Solomon. And with that, we close this session. Thank you for your engagement. All materials will be shared. Thank you. Bye-bye. Have a lovely week.
Thanks, everyone. Bye.
Thank you. Bye-bye.